callus. So now the soft tissue bridge is replaced by a bridge which is made up of bone. Clear? So the fracture site is bridged by bony tissue, and if there is bony tissue, what about strength? Strength will be there or not? Yes, so it is strong, very good. And this callus is containing calcium, right? So this is having calcium. Will it be seen on X-ray? Will be, yes, so it will be seen on X-ray. So if someone asks you, what is the earliest radiological evidence of fracture healing? Your answer will be callus, because callus is actually a bone, and bone is well visualized on X-ray. So hematoma, granulation tissue, callus. Now see, this callus is immature. Okay, so this is actually immature bone. Immature bone is also known as woven bone. So this callus is immature bone because the lamellae are very poorly arranged, and therefore if we look at the appearance, it is very irregular in outline. So what will happen in next stage? There will be conversion of immature bone to mature bone. So that phase is known as remodeling. Clear? So that phase is known as remodeling. And what is happening in remodeling? Immature bone is converted into mature bone. Right? Immature is known as woven and mature is known as lamellar. So this is the phase of remodeling, where if you look at the outline, it is becoming more organized. But what usually happens, this is periosteal surface. The outer surface is known as periosteal, and the inner surface is known as endosteal. Clear? So periosteal means outer, endo means inner. So what will happen in the last phase? There will be reshaping of the surfaces, and you can see here it is almost irregular, but later on it will become almost regular. So this phase is known as modeling. This is known as modeling. So in modeling phase, there is resurfacing of the endosteal and periosteal surface. So there is resurfacing or reshaping of endosteal and periosteal surface. Periosteal and endosteal surface. Clear? So these are the phases of fracture healing. So initially what is happening? There is collection of blood, that is known as hematoma. In that blood, there will be formation of fibroblast, osteoblast or blood vessels, and it will form a bridge between the two fracture ends, that is known as granulation tissue. Now granulation tissue is not strong enough to hold the two bony fragments together. So finally there will be deposition of calcium, and the granulation tissue will convert into bony tissue, and that bony tissue is known as callus, and callus now will bridge the fracture site. Then callus is immature bone, so it will be converted into mature bone. That is the stage of remodeling. And in the last stage, there will be resurfacing of the inner surface, endosteal, and there will be resurfacing of the outer surface, that is periosteal. And this modeling will reshape the bone in such a manner that it becomes very difficult for us to identify the site of fracture. Especially in children, we cannot identify what was the actual site of fracture, right? So these are the different stages of fracture healing. Now see what happens in first step, hematoma, and the second step, granulation tissue stage. These two stages are also seen in cases of soft tissue injury. But what happens in soft tissue injury, after this there is fibrosis. Clear? In soft tissue, after second stage there is fibrosis, but in a bone, after second stage there is callus. So initial two steps are same, whether it is bony tissue or it is any soft tissue. In soft tissue, there is granulation, there is formation of fibrosis. In bone, there is fibrosis, there is formation of callus. So this is how the process differs, although the initial two steps are almost same. Now, what is more important from exam point of view is the timeline of these different stages. And to remember these stages, there is one mnemonic, and that is like 1, 2, 3. So just keep these numericals in mind. Like if you see, the hematoma stage is lasting only till 1 week. So 1 you can see here. What about granulation tissue? 2, 3, right? Then if you come to callus, 1, 2, 3 in months. Then remodeling again 1, 2, but in years, and modeling is 3 in years. So what you can see, 1, 2, 3, that is repeated again and again, and we are getting the different timelines. But yes, you have to remember whether it is in weeks, months, or years. So this is very important, and most of the time we have a question about the timeline, like when you will see the granulation stage or the callus stage. And secondly, this one is very favorite. Earliest radiological evidence of fracture healing, your answer will be stage of callus formation. Now let us discuss few related MCQs. Now in the first MCQ you can see there is a 35 years old man who had a closed fracture of the tibial shaft. X-ray at 3 weeks. Now see, X-ray at 3 weeks shows soft tissue swelling and early new bone formation around the fracture ends. Which stage of fracture healing is this? So if you can see what is given, 3 weeks, number 1, clear? And what we can see here, that there is soft tissue. Okay, so soft tissue swelling is there. And lastly, there is one more important clue which is given. Very good. So early new bone formation. So based on this, what will be your answer? Now here you have to consider this word, new bone formation. And this new bone formation is actually what? It is callus. Clear? So yes, I do agree that time period is overlapping, but once there is formation of bone, it indicates that now the fracture has entered into the phase of, yes, so there is callus formation. If there was no mention of this particular fact, then definitely the answer would have been granulation tissue phase, right? So this is how you need to uh, you need to just evaluate what key points are given, and based on that you can reach up to the appropriate answer. Now take another question. A 20-year-old man presents 24 hours after a closed fracture of the radius. The fracture site is painful, swollen, and filled with clotted blood between the bone ends. Which cellular event predominates at this stage? So I think the time given is 24 hours. And which stage you can expect at this moment of time? Yes? What you can expect here? Very good. Yes, this is hematoma. Because we know that hematoma is less than 1 week or 7 days. So less than 1 week or 7 days. So this is how you need to just understand what actually is being given in the question. Then next question, a fracture X-ray was taken at 2 weeks. It shows tissue with fibroblast and newly formed capillaries bridging the fracture's gap. What is the stage of fracture healing? Very good. So 2 weeks, right? 2 weeks time is given. Fibroblast, then new capillaries, and there is bridging of fracture gap. Now what you can think? Yes, what will be your answer? 2 weeks. See, this all is granulation tissue. Okay, this is all granulation tissue. Callus is what? Callus is bone actually. Right? Callus is bone. Here, fibroblast, new capillaries, this is all soft tissue granulation phase. So the answer here is option B. So this is granulation phase. Okay. But this is only the soft tissue which is bridging. There is no mention of bony tissue. So this is granulation phase. The next question. At 6 weeks after fracture, radiographs show bridging of the fracture by calcified tissue, but the bone is not yet fully strong. Which stage of fracture healing is this? So there is the very firstly we need to write the duration. So this is 6 weeks. Then there is bridging by calcified tissue. But yes, strength is not fully strong. So what will be your answer? What do you mean by the word calcified tissue? Calcium, yes, calcified means bone. So what will be your answer? It will be soft callus. Okay? So this is soft callus formation because it is not fully strong. If the word was fully strong, then you could have gone for hard callus. So this is soft callus. Okay? And again, time period is very important. 6 weeks. 6 weeks is for which stage? Callus formation. Yes. Chalo. Next question. A patient with healed fracture regains normal bone contour and medullary canal over several months. Which process is this? See, fracture has healed. Number one, fracture healing has taken place, and now the bone contour is normal. So this is the which phase? The last phase. And last phase is which phase? Modeling. Very good. So your answer will be modeling. So this is how you need to apply the concept, and if you know the stages, the duration, especially related to the time, you can easily answer, right? So the very first important is note the time period. What time period is given? And remember the concept 1, 2, 3, 1, 2, 3 like that. And then you can never be wrong in your answer. The moment if there is any mention of bone, calcified tissue, obviously we are discussing something beyond the stage of callus. Okay? So this is how you need to solve this kind of question. Now another very important topic is dislocation of shoulder joint, and no paper is ever complete without including a question from this topic, right? So it is extremely important to know about shoulder joint dislocation. Okay, so we can continue with the dislocation of shoulder joint, right? So one of the joint which is very commonly dislocated in clinical practice is shoulder joint, right? So if someone asks you which joint dislocates commonly, the answer will be shoulder. So shoulder joint is the most common joint to dislocate in body, and the problem with shoulder joint is that if it dislocate once, there is always a tendency of recurrent dislocation. So not only it is the commonest joint in the body to dislocate, it is the commonest joint to dislocate again and again. So that is very problematic with shoulder joint. It has high tendency of dislocation, and if it dislocate once and if you don't treat it properly, it remains susceptible for dislocations again and again, right? And this is just because of the fact that glenoid is very shallow as compared to the head of humerus, which slips out. Now depending on the movement of the head of humerus with respect to the glenoid, it can be anterior, it can be posterior, or it can be inferior. So there are three varieties of shoulder dislocation which we see in clinical practice depending on the direction of the movement of the head of humerus. Either it can go anteriorly, so that is known as anterior. Either it can go backward, that is posterior, or it can slip downward, that is inferior. So anterior, posterior, inferior. Out of these three, which one is commoner? For shoulder it is anterior. Please remember, shoulder anterior, and the rarest one is posterior. For anterior, the usual posture of the upper limb is abduction, external rotation, right? Abduction, external rotation, and if there is a push from behind, the head of humerus will come out. And therefore, if I ask you about posterior, just reverse it, right? Adduction and internal rotation, right? So adduction, internal rotation, and if someone pushes, gives a blow from here, the head of humerus will move out. So this is the posture of upper limb at the time of injury. Abduction, external rotation, hit from behind will cause anterior dislocation, and adduction, internal rotation, hit from front will cause posterior dislocation of shoulder. Now posterior dislocation of shoulder is especially seen in two circumstances which starts with E. So one of the circumstances, epileptic fit. Clear? So if someone is having convulsive episode or epilepsy, there is high possibility of posterior dislocation, or electric shock. So in these two conditions, there is high possibility of posterior shoulder dislocation. So in majority of the questions, whenever we are asking posterior shoulder dislocation, we always include either epileptic shock or electric shock in the case history. So the moment you find a case history starting with a patient with epilepsy presented with this 99.9% it is going to be a case of posterior dislocation of shoulder. And here, what sign we will see? Again, you can use this word electric here. So this is electric bulb sign. So this is known as electric bulb sign. Okay. So the head of humerus, it will look like electric bulb. And the third one, which is the inferior variety, it is also known as luxatio erecta. So it is also known as luxatio erecta. Now erecta means what? Erecta means straight. So what happens, as the head of humerus slips below the glenoid cavity, the upper limb is abducted like this, and the arm is almost touching the ear. So very peculiar episode, presentation. Sub means below. So the head of humerus is below the glenoid cavity, and the upper limb is abducted in such a manner that the arm is touching the ear. The moment you look at the patient, you can say that this is a case of inferior dislocation, right? So luxatio erecta is another term for inferior dislocation. Okay. Now out of the three, the most common is anterior shoulder dislocation. So we will discuss anterior shoulder dislocation mainly. Now here you can see this is coracoid process. Okay. So this is coracoid process and what we see that the head of humerus is lying below the coracoid process. This is the glenoid cavity, and usually or normally the head of humerus should be here like this, but now it has slipped anteriorly. So this is an anterior shoulder dislocation. And what is the mechanism of injury? What is the posture of the upper limb? I told you abduction, yes, remember abir. So abducted and externally rotated upper limb and hit from behind. More chances of anterior shoulder dislocation. The most common subtype of anterior is the one where the head of humerus, so this is the head of humerus. So the head of humerus is lying below which process? Coracoid process. So that is known as subcoracoid. Sub means below. So the head of humerus is lying below the coracoid process, subcoracoid. Now there are three clinical tests which we do for anterior shoulder dislocation, although they should not be done because the patient is already in extreme pain. Now what we do, we tell the patient to touch the tip of opposite shoulder, right? And if the joint is normal, it is very easy for us to touch the tip of opposite shoulder. But if the joint is dislocated, the person will not be able to touch. So this test is known as Dugas test. Okay, so this test is known as Dugas test, where the patient is unable to touch the tip of opposite shoulder. Then secondly, look here, what we do, we actually measure the vertical circumference of axilla. So what we are measuring? Vertical circumference of axilla. Once the head of humerus comes down, the circumference increases, right? So look here, it is only this much, but look here, it is this much. So vertical circumference of axilla is increased in anterior dislocation, and this test is known as Callaway's test. So what is the name of this test? Callaway's test. And there is increase in the vertical circumference of the axilla. And why it is increased? Because of head of humerus. So head of humerus is occupying this space, and therefore it is increasing the vertical girth of the axilla. So Callaway's test. Now look at this test. What we are doing, we are putting a ruler or a scale. So we put a ruler and a scale, and this landmark is lateral epicondyle, okay, and this landmark is acromion. In a normal shoulder joint, we cannot touch both the bony landmarks at the same time. See, here acromion is not touched. And why? This is because of this prominence of deltoid, which is over the head of humerus. So because of this, the ruler is away from the acromion. But when the head of humerus dislocates anteriorly, we can touch both the bony landmarks. So this is the acromion process here, and this is the lateral epicondyle here. So both the bony landmarks are touched at the same time, keeping the ruler vertical. So this test is known as Hamilton ruler test, right? Ruler, or you can say scale. So normally we cannot touch both the landmarks if the shoulder joint is normal. In cases of shoulder joint dislocation, the two landmarks can be touched simultaneously. So these are just theoretical tests one should not do because it is extremely painful. Now, what is the treatment? It is an emergency. Okay, so it is an emergency, and therefore what you need to do, you have to put back the head of humerus into the glenoid socket. So the head of humerus is lying here, you need to put it back into the glenoid. So that is known as reduction. So reduction means getting pre-injury status. It can be reduction of fracture, it can be reduction of joint dislocation. And why we are using the word closed here? Because we are not giving any incision. We are just pulling, so it is closed. And the technique which we commonly use is known as Cocker's maneuver. Which maneuver? Cocker's maneuver. The different steps of this Cocker's maneuver can be remembered by the mnemonic team. So you can remember the mnemonic team. T means traction. Okay, T means traction. It means you have to pull. E is external rotation. Very good. So E is external rotation. External rotation is what? Like this. If we flex the elbow and if we take the palm outside, this is external rotation. Then after that, A for, here it is adduction. Adduction means bringing the elbow to the midline, chest. So this is adduction. And after this, the last step is neutralization. So we have to neutralize this. So what is the opposite of external rotation? Internal rotation, that is also known as medial rotation. Clear? So medial word is actually internal only, nothing new. So this is internal rotation. So just to make the mnemonic, we are using the word M, otherwise it is internal rotation. So what we do? Traction, external rotation, adduction, medial rotation. Simple. So this is the Cocker's maneuver. Now what is very frequently asked is about the complications. There are two important complications which you should know. One, I already told you, if there is dislocation once, there is possibility that it will dislocate again and again. And what term you will use for that? Again and again means recurrent. Okay. Recurrent means again and again. And anatomically, there is one nerve which winds round like this. So there is a nerve which goes like this, and this nerve is axillary nerve. Which nerve is this? Axillary nerve. So if there is dislocation, it can cause injury to axillary nerve. So if someone asks you which nerve is injured, your answer will be axillary. So two important complications of shoulder dislocation: axillary nerve injury, recurrent dislocation. Now what are the changes which we see in a case of recurrent shoulder dislocation? There is some change to the glenoid component, there is some change in the humeral head component. Now what happens? The glenoid cavity is deepened by a fibro cartilaginous labrum. So what happens when the head of humerus is dislocating again and again? It will pull the labrum, or it will cause tear of the labrum. That is known as Banker's lesion. What is that known as? Banker's lesion. So Banker's lesion is actually tearing of glenoidal labrum. So tearing of glenoidal labrum. You can see here, especially from the inferior part, it is detached from the bone. So this is Banker's lesion. And what is the lesion on humeral head? Very good. So this is Hill-Sachs lesion. So this is Hill-Sachs lesion, because what happens? Glenoid is hard bone, but head of humerus is cancellous. So every time it strikes, there is indentation fracture, especially on the posterolateral part. The posterolateral part, there are small indentation fractures. So there are small indentation fractures. Okay. So now how you will remember which area is affected in Banker's, which area in Hill-Sachs. So remember H of humeral head and H of Hills. So that is how you can remember it. Now taking up some questions. Athlete presents with the fall with the arm abducted and externally rotated. Now after this, the patient is not able to adduct. What type of dislocation is this? Very good. So we can write AB and ER. The moment you have this word, yes, abduction acceleration in shoulder joint, go for anterior shoulder dislocation, right? So the answer will be anterior. So is that clear? So this is how you can, and yes, the opposite movement will be not possible. Now a patient with anterior shoulder dislocation has loss of sensation over the regimental badge area. Which nerve is injured? I think everyone can answer this, because I just told you that axillary nerve is commonly injured. Now what is this regimental badge? Any idea? Regimental badge is actually this area. So army uniforms or police uniforms, they keep their regiment badge here, and this is the area which is supplied by axillary nerve. So if axillary nerve is gone, in this much area, if you prick with pin, patient will not feel, because there is no nerve supply. So this is known as regimental badge sign. What is this? Regimental badge sign. So this area is supplied by axillary nerve. If axillary nerve is paralyzed, patient will have no sensations here. Chalo, next question. A patient have recurrent anterior shoulder dislocation. Now there is detachment of anteroinferior labrum on MRI. What is this? Labrum. Bankert. This is glenoid labrum, right? So labrum is what? Bankert lesion, right? And Hill-Sachs is on humeral head. This is humeral head. Humeral head fractures. Clear? So this you need to remember. Now which bony defect is classically associated with anterior shoulder dislocation? Now this is especially recurrent, especially with recurrent. With recurrent anterior dislocation, which part will fracture commonly? Now again here, what you need to remember, the question is about Hill-Sachs. So the question is about Hill-Sachs. So what will be fractured in Hill-Sachs? Remember H for Hill and H for humeral head, right? So the answer will be this, compression fracture of the posterolateral humeral head. Okay. The next question, a patient has shoulder dislocation followed by electric shock. The moment you have this word electric shock, so what thought should come to your mind? Which dislocation? Posterior. The moment you have electric, so you have make up your mind that yes, it can be a case of posterior. Now head of humerus shows the head lying posterior to the glenoid. So yes, this is a case of posterior shoulder dislocation. Now the question is about, not about diagnosis, it is about something else. Now the question is asking which movement is restricted. Now what should be the posture of the upper limb for posterior? It should be AD, that is adduction, and IR, added. So what will happen? The opposite movement will not be present. So what is the opposite of adduction? Yes. So this is not possible because the limb is adducted. Clear? So this is how you will associate. So this is opposite. So opposite is not possible. And we discussed in first question also. The patient is unable to adduct. So again this is opposite, right? So opposite is not possible. Opposite movement. Then yes, next question. A patient has inability to abduct shoulder beyond initial 15-degree following dislocation. Which muscle is affected? So initial, very good. So 15-degree of abduction. And we know that which muscle is responsible for this? Supraspinatus. 15 to 90-degree deltoid. So this is very unique for shoulder joint because different degrees of abduction of shoulder, different muscles are coming into play. 90 to 120-degree, trapezius and sternocleidomastoid. Clear? C. Serratus anterior. Serratus anterior. Right? So the question is about 15-degree. So the answer will be supraspinatus. And sometimes they can ask you nerve paralysis. So you should know which nerve is supplying supraspinatus. It is suprascapular nerve. Because muscles cannot paralyze until the parent nerve is paralyzed. Right? The most common complication following anterior shoulder dislocation. Very good. So once it dislocates, there is high possibility of dislocation again and again. Right? So this is how you should know the concept and how a particular concept can be framed into, a complex looking question. But if you just read the statement properly, you can answer. Okay. So now moving forward to next topic, this is hip dislocation. Also this is very important, and most of the time we have question from this segment also. Again, if this is acetabulum, this is head of femur, it can go anteriorly, it can go posteriorly, and there is a very unique type of dislocation where the head of femur can perforate through the acetabulum and it can go into the pelvic cavity. So there are three types. One is obviously anterior, second is posterior, and the third one is central. What is that? Central. So anterior, posterior, central. What was the most common variety in shoulder? Anterior. But the most common variety in hip is posterior. Okay. So posterior hip dislocation is the commonest one. It is the most common variety. And how it happens? What is the mechanism? If a person is sitting in the car and if there is accident, what happens? The body is in motion, it will go forward, and the knee will strike the dashboard, and there will be a back pressure which will be generated along the shaft of femur, and it will take the head of femur out of the acetabulum, and therefore this is also known as dashboard injury. So it is also known as dashboard injury because that is the usual mechanism of dislocation. Now what is the attitude of limb in posterior hip dislocation? The moment you have this word posterior hip dislocation, you have to remember the mnemonic. What was the mnemonic for shoulder, posterior shoulder? Posterior dislocation shoulder, right? So here you can write flexion, adduction, internal rotation. So almost it is same. So F for flexion, AD for adduction, and I for internal rotation. So remember FADIR. Okay, so clinically we can see a patient, like if suppose this is the normal foot, how we see the abnormal, the injured one is something like this. Clear? So this is the injured side. So what is happening? It is touching the opposite knee. So this is adduction. The medial border is lying, the medial border, see this is the normal orientation of the foot when we are lying supine. The toe should face towards the ceiling in 15 degree of external rotation. But if there is internal rotation, the toes will face like this. And if there is external rotation, the toes will face like this. So very easy to identify. So the toes will point like this. The knee is touching the opposite knee. So this is the adduction. This is internal rotation. So very easy to identify. The moment you look at the patient, you can say this is a case of posterior hip dislocation. Now what we see on X-ray? You should remember one line. What is the name of this line? Okay, what is the name of this line? Any idea? Shanton line, very good. So, this is the medial neck of femur, okay? And this is the inferior border of the superior pubic rami. So if we join these two landmarks, it forms a smooth curved line, and this line is known as the Shanton's line. So this is the Shanton's line. Okay. Now look on the other side. The Shanton line is broken. So one of the important feature is broken Shanton line. And remember, this is non-specific. It means if you see a broken Shanton line on X-ray, it does not always mean that it is a case of hip dislocation. It can be seen in any case if there is fracture of superior pubic rami, because this is one component. It can be broken if there is fracture neck of femur. So, but this is just a radiological feature. Now secondly, what you need to do? You have to draw a line from the midline like this. And see what is happening. What is happening here? The femur or the leg is going towards the midline. So this is which movement? Movement of a limb close to the midline. What do you call that? Adduction. Right? So what is this? Adduction. And thirdly and most importantly, what prominence is this? This is lesser trochanter. Okay, so this is lesser trochanter. Now look here, on this side we cannot see lesser trochanter. So lesser trochanter is not visualized, and this means that there is which deformity? Internal rotation. So on X-ray, two deformities we can see, internal rotation, and second deformity is which one? Adduction. So again, we can see adduction, we can see internal rotation. So these two are visualized on X-ray. So very easy to diagnose clinically. And for every reduction, every dislocation, what you need to do? You have to do emergency reduction. So that's important. Here we can use Stimson's gravity method or Ellie's method. Now, complications, again very important in orthopedics. Which nerve can be paralyzed? There is a very thick nerve on the posterior aspect of the hip joint, especially related to gluteal region, and that is sciatic nerve. Which nerve? So there is possibility of injury to sciatic nerve. There can be disruption of the blood supply to the head of femur, and it can go into what complication? Very good, avascular necrosis. A means without, vascular means blood supply, necrosis means death. So the head of femur can die. And thirdly, there can be formation of new bone that is known as myositis ossificans. Clear? So this is for posterior hip dislocation. We can take 5 minutes break and then we'll continue. expression or like you'll be
repeated, some are repeated.
because I think Bangladesh because they should not repeat. Bangladesh is extremely good. I have heard so Bangladesh, Nepal. But anyway, like there might be some some deficiencies in your approach, the way you prepare or solve paper. So there may be some application might be problematic.
Yes, sir.
I think all of you must be good. So actually, what we planned like sir was saying that we have to start class, we have to start class.
Actually, you are very thankful that taking your time here in this and it's important.
So we really appreciate for your permission.
Thank you so much. So I just plan to come with some like some good topics, some related questions because at this moment it's not wise to go with the entire syllabus. So we will just take important topics and solve some related questions. And whatever little you read, just make sure that you don't commit any mistake in the exam. So read less, practice more, rapid revision, and skill time, that will work. And hopefully this session will be comparatively easy to clear.
Yes, sir.
Because July is really tough, really tough. So we can start. Okay, so we can move forward. So we just discussed posterior, and some of the things you can, if you can reverse, you will get anterior. So for posterior, what was the attitude? Fadir, right? So for posterior, we discussed fadir, right? So fadir. And for anterior, yes, so anterior, well, F is common, okay, F is common in both, and then you will write abir, so it will become fabir. Yes, right? So is this clear? So for anterior, the shoulder, the hip joint is externally rotated and adducted. Now these clues are very important because if you can remember this much, sorry, right. Yes, I'm sorry. This is abducted. Sometimes actually planning, thinking now what he is doing. So, right. So this is Faber. Okay. So now if I ask you, what is the attitude of limb in anterior hip dislocation? You will say Faber. Okay. So you will write Faber. What was the attitude in posterior? It was Fadir. Here it is Faber. So F for flexion, abduction. Yes, very good. Flexion, abduction, external rotation. Now abduction means the lower limb will be away from the midline. External rotation means the, if suppose this is the foot, the lateral border will be touching the couch. So this is external rotation. Okay. So easily we can just diagnose it on clinically. Now look here. This is acetabulum, and this is the head of femur. Obviously we can say that it has moved outside, so there is dislocation, because normally it should be somewhere here, but it has moved away. So it's a case of dislocation. But how to say whether it is anterior or posterior? For that you have to check which landmark? You have to check lesser trochanter. Brother. Right? So you need to check lesser trochanter. And what we can see here, see, this is the lesser trochanter on the other side. Just compare the two. The one on the injured side is very prominent. And prominent means that there is which deformity? External rotation. So suppose if this is the femur, if it is internally rotated, the lesser trochanter will come behind and we cannot see it. If there is external rotation, it will come in front and we can see it prominently. So if lesser trochanter is good, is prominent, it means there is external rotation. Again you can do one thing, draw a line from the middle and see the femur is moving away from the body. So this is which? This is abduction. So on X-ray you can see two things, abduction and external rotation. And the moment you have abduction, external rotation of the hip joint, without any doubt you can say it is a case of anterior hip dislocation. Okay, so this is how you can answer it. Now in anterior hip dislocation, suppose this is acetabulum, the head, it is coming in front. So it can injure one nerve. Which nerve it can injure here? Now here the head of femur is coming in front. So here it is femoral nerve. Right? So which nerve? Femoral nerve. Because it is anterior. If it has gone posterior, then sciatic. So please remember this. Okay. Then avian can happen because there might be disruption of the blood supply to the head of femur. Now look in this X-ray, what we can see. This is acetabulum which is broken, and this is the head of femur which has moved inside the pelvic cavity. So it has moved inside the pelvic cavity. See, this is the normal location of head of femur, but here the head of femur is lying like this. So this is known as central hip dislocation. Sometimes we also add the word fracture because there is fracture of which bone? Acetabulum, right? So there is fracture of acetabulum or acetabular floor. Okay, like so. In which direction the head of femur is going? Inside, or if we draw a line like this, it is going towards the midline. So it is forced medially through the floor of acetabulum. So it has perforated the floor of acetabulum. And if you do a per-rectal examination, you can feel the head of humerus. Very good. So head of femur, sorry. Head of femur can be palpated on per-rectal examination. Again, there can be avian because the arterial blood flow to the head of femur can be disrupted. So this is central fracture hip dislocation. Now let us take few questions. A man presents with road traffic accident. His lower limb is shortened, adducted, internally rotated. So this is adducted, internally rotated. Now what you will say? Yes, so you can add F also, so it will become FADER, and we know that FADER stands for posterior. Okay, so this is how you can answer this: adducted, anterotated. Now if I ask you which nerve is commonly injured in posterior, sciatic. Very good. So this is sciatic. If the question was about anterior, then you have to mark femoral. So please remember anterior, right? A patient presents with hip dislocation where the limb is abducted, externally rotated, and slightly flexed. What is this? Very good. So this is F, AB, and this is, yes, so this is Faber, and we know that Faber defines anterior dislocation. So very easy if you know the basic concepts. You will never be wrong. Which radiological sign is characteristic of posterior dislocation? Now here I am using the word characteristic. It means you have to tell that sign which is suggestive. It should not be seen in any other condition. So this is lesser trochanter, not visualized, because what is the posture? Flexion, adduction, internal rotation. Because of internal rotation, the lesser trochanter will hide behind the shaft, so it is not seen. So this is specific. This is also seen, but it is not specific. Shenton line can be broken in many conditions. So if I write broken Shenton line, it can be broken in anterior hip dislocation, it can be broken in posterior hip dislocation, it can be broken in fracture neck of femur, it can be broken in fracture superior pubic rami. So therefore I told you before that it is non-specific. Clear? It is non-specific. It does not relate to one particular condition. So therefore it will, though it is seen in posterior hip dislocation, but it will not be the answer here. The most serious early complication of hip dislocation. What do you think? The word is serious, and serious is always vascular insufficiency. Okay, so this is serious. Sciatic nerve palsy can also occur, but that is not serious. What is the ideal time limit for reduction of traumatic hip dislocation to reduce complications? I told you that whenever there is dislocation, it is an emergency. How we take it? We take it as an emergency. And for emergency, what should be? As early as possible. Clear? As soon as possible. Just because this is the minimum limit given here, we are writing 6. But suppose if there was limit of 2 hours, 1 hour, then definitely we should have gone for the minimum time duration, right? So considering the 4 options, this is the minimum. So otherwise the fact is as soon as possible. CT scan is most useful for what? Remember, CT scan is what? It is modified X-ray. CT scan is nothing but a modified X-ray. We can take views in multiple plane, right? So what we see on X-ray? We always see bone in a better manner on X-ray. So what will be your answer here now? Very good. So only bony option is acetabular fracture. See, for soft tissue, MRI. Labral tear is soft tissue, MRI. Muscle is soft tissue, so MRI. So for all soft tissue, X-ray, CT scan is of no use. It is only good for bony fractures. Then moving forward to acute osteomyelitis. Acute means, what is the term acute? Short presentation, very good. It can be hours. So, an acute means that the organism is highly virulent. Highly virulent. Virulence is what? Disease causing capacity. Osteo is bone. Myelo is marrow. And itis is inflammation. So this is the definition. Now what happens? There are two ways in which osteomyelitis can happen. Suppose there is bacteria lying somewhere in the skin. The bacteria is in the skin, and what is happening? This is bone. So this is the blood channel. So bacteria will gain entry into the blood channel and it will travel all the way to bone. So this type of spread of bacteria from one area to another area through the bone is known as hematogenous. What type of spread is this? Hematogenous. And this type of osteomyelitis is known as primary. Clear? So in children's, the most common one is primary. And what is the route of spread of primary? Hematogenous. So it is hematogenous. Sometimes what we see in clinical practice, that if we operate on a bone and if we don't follow sterile techniques, it can get infected. And if there is an infection in orthopedics, it is very difficult to treat, and such entity is known as secondary osteomyelitis. Right? So secondary osteomyelitis because of open or compound fractures. What do you mean by the word open or compound fractures? It means whenever there is a fracture, the skin coverage is lost. The fractured area is communicating directly with the environment, and high chances of entry of the microorganism into the fractured area. Or sometimes if we are doing any surgery of orthopedics where the sterile techniques are not followed, it can lead to infection. So two conditions, and therefore in older times when the sterilization procedures were not good, the orthopedicians, they were very fearful of operating because they know that if we operate, it will go into osteomyelitis. So what they used to do, they used to apply cast. But nowadays we have good surgical techniques. So operative management has been the procedure of choice, especially for adults. So we will start with primary osteomyelitis. The joint area which is very common site is the knee joint, and we know that in knee joint there are two bones. So number one is lower end of femur and number two is upper end of tibia. So knee joint is the usual joint which is affected, and if we talk about bones, lower end of femur is number one, followed by upper end of tibia. Very good. So this is the sequence. Upper end of tibia. Now in a bone, especially in a child, we know that there is epiphysis, growth plate, metaphysis, and finally diaphysis. So out of the four, which one is commonly involved in primary? Any idea? Suppose if this is the long bone, so this area is physis, okay. So this is epiphysis, this is physis, this is metaphysis, and this is diaphysis. So out of the four, which one is commoner? Yes, so bacteria will reach here first. Okay, so metaphysis is the commonest location or site in primary osteomyelitis. So it is metaphysis. Now the question is, why metaphysis and why not diaphysis or epiphysis? Why? Because it is highly vascular area. Clear? So this is highly vascular. Highly vascular means good amount of blood supply, and we know that how the bacteria is traveling. It is traveling in the bloodstream. So the area which is having more blood flow will have more inflow of bacteria. Therefore it becomes a favorite spot for osteomyelitis. Apart from this, there is very typical arrangement of the blood vessels. So this is known as, yes, what is this known as? Especially girls, they should know what they put on the hair. So this is hair pin. Clear? So this is hairpin arrangement. So here we will write hairpin arrangement, and what happens because of this turn like this, the speed of the blood is slowed down and bacteria, they can move out of the vascular channels. Number one. And metaphysis, it is, so metaphysis is the growing highly vascular area and with hairpin arrangement. Now it is growing area, so WBCs are also immature here. So immature WBCs means what type of defense? Good or bad or poor? Yes, so defense mechanism is also poor, not that well developed to tackle bacteria. So this is in short about pathology. Now we discussed that the bacteria is having high virulence, and which usually this bacteria is Staphylococcus aureus. So most common organism in acute osteomyelitis is Staphylococcus aureus. Now this is for normal population. There is a different set of patients like sickle cell anemia. Here the condition is caused by a different bacteria, and that bacteria is Salmonella. Okay. So if the question is about general population unspecified, you will write Staph aureus. If the question is about sickle cell anemia, the answer should be Salmonella. Normally it is affecting which part? Metaphysis. But in Salmonella it affects diaphysis. This is one more difference. So diaphysis here, metaphysis here. Okay. Now what we see on X-ray? Initial changes are seen in soft tissues, but if someone asks you about X-ray, then early x-rays may be normal. You cannot see any change in x-ray, and therefore what happens most of the time, especially newcomers, they say that this is not a orthopedic problem, go to pediatrician. But in reality it is a orthopedic problem, and that this what results in delayed diagnosis. And therefore what we say, whenever you see a child less than 10 years of age come with presenting to you with high grade fever, pain, swelling, tenderness around knee joint, 99.9% it is a case of acute osteomyelitis. Always consider it as a case of acute osteomyelitis, and therefore we use the word clinical diagnosis. So diagnosis of acute osteomyelitis is always clinical, based on the presentation of patient. X-ray is not going to show you anything, so don't rely on X-ray. The presentation should think you about the diagnosis, right? And yes, from exam point of view, if someone asks you about X-ray changes, the earliest X-ray change is known as periosteal reaction, but it takes at least 10 days, right? So it takes around 10 days, and therefore we don't trust X-ray for making diagnosis of acute osteomyelitis. And what is this periosteal reaction? It is actually because of inflammation, there is additional new bone formation over the periosteum, so it is known as periosteal reaction. So suppose if this is the bone, what happens on X-ray, we can see an additional white line like this. So this is known as periosteal reaction, but don't trust this. So what are the options with us to make a clinical diagnosis? We know that bacteria is roaming within which channels? Blood channels. So what we'll do, we'll take a sample and we will send it for culture. We will try to grow the offending bacteria. So this is known as blood culture. So take a blood sample and try to grow the bacteria, and at the same time check the antibiotic to which it is sensitive. So you will go for blood culture and sensitivity. In 65% of cases we can detect the offending bacterium, which is usually Staphylococcus aureus. Okay, this is one thing. Now whenever a patient comes to us, the usual tendency is to give antibiotics. Don't do it. Firstly take the blood sample, then start a broad spectrum antibiotic, and once after 3 days when you have the report, read which drugs are good, replace the one which you have started with the one which is shown in the report. So that is actually the practical way how we go for that. We can do bone scan, which can show increased uptake in the metaphyseal area, but the modality of choice is MRI. So MRI is the investigation of choice, and we can diagnose the condition within 48 hours. Now here this value is very important, 48 hours, because if suppose if we take this value, if the patient reports to us within 48 hours, conservative treatment is, it can give you results. So antibiotics is effective. But if the patient is presenting to you after 48 hours, then what happens? Pus has formed, and once the pus forms, what is your management? Antibiotic or surgical? Very good. So we need to go for surgical drainage. We need to, yes, in soft tissues we do incision drainage. So therefore this period is very valuable for us, because it guides us as to the approach for management. Less than 48 hours, we can take a chance with the antibiotics, and we are hopeful that it will resolve with antibiotics. But if it is more than 48 hours, presume that pus is now formed and we need to do drainage. In bones, we cannot do incision, we need to make drill holes. Then only the pus can come out of the metaphysis outside. So this is the approach. So management is with broad spectrum antibiotic. And I told you what is the approach. Take the sample, send it for culture till the time start any broad spectrum antibiotic, and once the report comes, replace it with the one shown in the report. And after 48 hours, we know that pus has formed, so we need to do drainage, and that is done by making drill holes in the bone. Now, what can be the complication? Acute can go into acute can become chronic. Clear? So acute can become chronic, and this is very fearful because once it goes into chronic, treatment is almost not possible. So that's a torture for patient and also for the doctor, because results are usually not good, and most of the time the infection cannot be eradicated. So it can go into chronic. Now in chronic, you need to remember two terms. One is sequestrum and another is involucrum. Very good. So many times we have question on these two terms, sequestrum and involucrum. Now what is sequestrum? Very good. Dead bone. So actually the exact definition is dead piece of bone lying within the infective granulation tissue, but for the time being, dead bone. Involucrum is new bone, because what happens when some part of the bone is dying, body tries to compensate it by producing new bone. So that new bone is involucrum, and it is an attempt by the body to minimize the loss because of formation of sequestrum. And once there is chronic osteomyelitis, the strength of the bone is weak and it can fracture with minimal trauma. Such type of fractures are known as pathological fracture. Such type of fractures are known as pathological fractures. So what do you mean by the word pathological fracture? There is a pathology, it has weakened the bone, and now the bone can be fractured by minimal trauma. Otherwise, to fracture a bone, we need high force or high velocity trauma. Then particularly if the metaphysis is intracapsular, or okay, so we can write the word capsular here. Intracapsular. What can happen? There is infection. The infection can spread to the joint. So it is known as acute septic arthritis. Normally what happens? The physis is resistant to infection, right? So usually, suppose if the capsule is attached like this, the infection can only come out in this manner. So it will be always outside the joint. So say this is the joint space. So it can never enter into the joint. But think of a case where the capsule is attached like this. If this is the capsule, so what is happening? The pus is directly going into the joint space. So it can involve joint. So there can be involvement of the joint, and that condition is known as septic arthritis. So septic arthritis will only taken as a complication if the metaphysis is intracapsular, right? And physis can be disturbed at times, and that can lead to growth plate disturbance. Growth plate is what? It is actually metaphysis. So there can be problem. There may be deformity or limb length inequality. So again, take a question. 7-year-old boy with fever, pain, swelling around the knee joint. Right? Very classical presentation. Swelling typically around the knee joint, and the culture is showing Staphylococcus aureus, and so this is a classical case history of which condition? Acute osteomyelitis. Very good. And we know that acute osteomyelitis involves which part of bone? Metaphysis. So in older times they usually frame most common site of acute osteomyelitis, but nowadays simpler things, they are just creating a clinical scenario, and then they are asking that particular thing. Which radiological finding is typically seen earliest in acute osteomyelitis? Now, earliest is actually soft tissue swelling. It can be seen around 4 days. Periosteal new bone formation will be seen after 10 days. So it is not earliest. Sequestrum, cloaca, these are both chronic osteomyelitis. Clear? So earliest is soft tissue swelling. A child with acute osteomyelitis has subperiosteal abscess. Now what is the reason for lifting of this periosteum? Suppose if this is the bone, right? Suppose if this is the bone like this, okay? Here this is the growth plate, and then this is all, say, epiphysis, and there is a covering, and this covering is known as periosteum. So what is happening? The pus, it is coming like this. So this is periosteum. So what is happening? There is lifting of periosteum. So what is the reason for lifting of periosteum? Accumulation of pus which is lying below the periosteum. And why it is happening? Because this physis is very resistant. It will not allow to go inside. So the pus is coming outside by breaking the metaphysis, cortex of the metaphysis. And we know that once a pus is formed, it will always make its way. It will not stop at one place. It will make its way. And that's why we always say we should drain pus, otherwise it will make its own way. So accumulation of pus under periosteum. Which complication is most likely if acute osteomyelitis in a child is not adequately treated? What you can think? There can be damage to growth plate, and this can lead to deformity. Okay, so this is how you can remember. Then we come to osteosarcoma. Now what you can see in the X-ray? Yes, so this we see calcification like this, and this is known as sunray appearance or sunburst appearance. Now remember, there are few terms which you should know. See, we know that there are two types of tumor. One is benign and second is malignant. So there are two class of tumors, benign and malignant. And what we need to do? We need to put two things. One is unspecified, and secondly specifically primary. Now if I ask you, which is the most common benign tumor of bone, the answer will be, osteochondroma. What is this? Right? Most common benign tumor of bone, osteochondroma. Now if I ask you, what is the most common primary benign bony tumor? Then your answer will become osteoid osteoma. So see, I am just putting one word and the whole meaning is changed. Unspecified osteochondroma, primary osteoid osteoma. Similarly, unspecified, the answer will be secondaries, and if I use the word primary, the answer will be multiple myeloma. Right? So please remember this value. And first is multiple myeloma, second is osteosarcoma. Clear? So second is osteosarcoma. So that's why it's written here. Osteosarcoma is the second most common primary malignant tumor after multiple myeloma. So multiple myeloma is the most common primary malignant. This is very important. Primary malignant. If I don't use the word if I don't use the word primary, then answer would be secondaries. Secondaries means the tumor has originated somewhere else and now it has invaded the bone. It is seen within 15 to 25 years of age. In which part of the bone? Epiphysis, metaphysis or diaphysis? It is in metaphysis. So osteosarcoma is in metaphysis. And just remember the locations of acute osteomyelitis. Same you can remember. Which joint? Knee joint. First is lower end of femur and second is upper end of tibia. So the sequence is almost same. Acute osteomyelitis. Now some conditions are at risk, especially one ocular condition, and that is retinoblastoma. Clear? So one is retinoblastoma. Then it can be seen radiotherapy, Paget's disease, bone infarcts, or sometimes fibrous dysplasia also. So in such cases, we should be very alert for the development of osteosarcoma. Now, in X-ray, there are two terms which you should remember. One is sunray appearance or sunburst appearance, right? So sunray or sunburst. And what is the another term? Very good. So you can see a triangular piece of bone, and this is known as Codman's triangle. Now remember, Codman's triangle is again non-specific. So it means it can be seen in some other condition as well, like Ewing sarcoma. So what is happening here? The periosteum is lifted. This is the cortex, and in between the two there is a triangular bony component known as Codman's triangle. And sunray appearance, why it is happening? Because of calcification. Because of calcification. And the calcification, it can be seen along blood vessels or Sharpie's fibers. Clear? So this is sunray appearance. And this is one tumor where the cancer cells are forming new bone. So this is very important. So new bone formation by cancer cells. Now this tumor is very aggressive. It means it can rapidly metastasize, and where it goes? To the lungs. So there is metastasis, and patient will come to you with hemoptysis. And if you do chest X-ray, you will see cannonball shadows. It is radio resistant. It means there is nothing if you give radiotherapy. And the prognosis is extremely bad. Despite trying many modalities, ultimately the patient dies. So let us take some questions. A 15-year-old boy, right? See, look, in tumors, age is very important. Okay. So the very first thing, if there is a question about tumor, always highlight the each first. Then second is joint, pain swelling around joint. Then there is third is location in the bone, metaphysis here, and C, distal femur. And then there is lytic or sclerotic. Lytic means the bone is damaged. Sclerotic means the new bone is formed. And this word is very important here, sclerotic. So this is the explanation to that. And yes, the easiest clue is sunburst. So yes, so moment you have this much of clues, the answer will come out to be osteosarcoma. Even if you don't have sunburst, you could have gone for, so 15-year knee joint and metaphysis. These 3 points should be enough to make a diagnosis of osteosarcoma. What is the histopathological feature of osteosarcoma? I told you that they produce new bone. And new bone is what actually? It is osteoid. Because osteoid is the basic substance over which calcium deposits and bone is formed. So tumor cells, they form bone, that is actually osteoid. A teenager with osteosarcoma comes to for staging. What is the most common site of metastasis? Very good. So it is lungs. Okay. So this is how you should remember the things, and always whenever you read theory, don't forget to solve questions, because that will, that will make your theoretical knowledge better. So this is enough for this session. So we will discuss, like if your people are interested, I will discuss with sir. And I have an art, physio, biochem ready with me. So if you are interested, I can finish those subjects as well in the same manner. Like 17 topics for anatomy, 17 for physio, 17 for biochem. So that I will discuss and then I will let you know. Right? So thanks for joining and all the very best for your exam. God bless.